We're waiting for Dr. Aib to join us. It start in 2 minutes.
Hello, Dr. Yusuf.
Hello. Sorry, I had some connection issues.
Okay. So would you like to check your presentation?
Okay. To share my screen?
Yes, we can test
Yeah, okay.
if everything is good. Yes.
Can you see my
Can you
screen
make
now?
it not in full screen mode? If you can make it in full screen mode. Yes, now perfect. Yeah, that's good. We are still waiting for Professor Aib to join us. It's already in time. So, Ahmad, we can start, or should we just wait for 2 minutes, Dr. Aib? Yes, Dr. Aib.
Yes, hello.
How are you,
Hi.
Professor?
Absolutely good. Ahmed, how are you doing?
Yes, yes, I'm fine, Professor. Thank you for asking.
All good. I'm here. I'll be moderating. So we have our presenters already.
Yes.
Okay, right. Good. Go ahead. I'll let me know what you expect of me, and I'll be happy to oblige. So let me know. The presenters are Yusel and Mohammed and Amit, I suppose.
Yes.
Okay, right then. Okay, go ahead, please.
Okay.
Okay. Welcome everyone to our third webinar of the comprehensive neuroanatomy course, arranged and that coordinated by Yemen Neurosurgical Society in coordination with WFNS, Young Neurosurgery Forum, and the Neurosurgery Coach, and Walter Dandy, Yemen Student Club, and also the Neurosurgical TV, and also the Pakistani Society of Neurosurgeons. Today we have 3 presentations with the distinguished speakers. So Dr. Aib, please you can introduce the speakers.
Should I start my presentation?
Yes, Dr. Muhammad, you can start. Dr. Aib will
Okay, I'm sharing a screen.
introduce. Okay.
Okay, is it visible?
Yes, it's good.
Yeah, it is visible. Go ahead,
Okay,
please.
I'm Dr. Nawaz, head of Neurosurgery Department, leading hospital from Pakistan. We have a busy hospital and a busy department of 110 beds, in which we operate bone, brain, and spine, both type of procedures. Today, I'm going to present surgical anatomy of the nose, the notion nose for neurosurgeon. It's basically for the residents and for the beginners. Well, as all of we know, nose is a battlefield for the ENT surgeons. Basically, 1/3 of their surgeries and their field is in the nose, but it's an important gateway or pathway for us to navigate through the base of the skull. And a lot of procedures, endoscopic procedures like the pituitary procedures through transphenoidal endonasal endosinus surgeries, and the extended approaches through the planus sphenoidal and through down to the clivus to remove the cardomas, to remove tuberculum meningomas, and the rest of the planus sphenoidal meningiomas. All of them are through the endonasal endosinus surgery. And if I dig a bit more deeper, so we can give an example of CSF leaks, which we do repair via endoscopic endonasal approach. And nowadays, another approach is being getting popular, that is endoscopic endonasal optic nerve sheath fenestration through the lamina papyracea. So the crux of this whole discussion is that understanding the anatomy of the cavity or the landmarks of the nose is a navigation tool or Google Maps for us to go to the skull, base of skull, where we actually do the work. So this presentation is aimed at reviewing the relevant anatomy and basically reviewing the landmarks which will help us guide to the base of the skull. So the nose. As all of you know, nose is a pyramidal shaped structure which is beautiful and applied to the front of the face. Its tip is upward and the pyramid base is downward. It has been divided into the two cavities basically by a nasal septum, and it opens anteriorly via two openings, which is called nasal apertures or nasal nares, nostrils, and behind it communicates with the nasopharynx via large opening, that is the choana. So if you see the nose, some of these terminologies are important, like the area between this eyebrows is called the root, and the tip of the nose is actually the apex. Our residents get confused when we discuss it with them during our routine endonasal endoscopic surgeries. They take it as a common and they use layman terminologies for it. And this is the area is called the nares, and the dorsum of the nose is actually the bridge of the nose, right? So this is about the surface anatomy. Now coming toward the external structure and the bony structure of this nose. This pyramid is actually osteocartilaginous framework, which is covered by muscles and skins. Basically, if I sum up and summarize, it's upper 1/3 of made up of bone, while the lower 2/3 is of cartilaginous framework. The bony part consists of two nasal bones, which meet in the midline, and the rest of the upper part of the nasal processes of the upper part of the nasal process of the bones. Like if these two bones are the nasal bones, and these are joining here, the nasal processes of the frontal bone. And on the bones, both sides, if you can see, the frontal processes of the maxillary bones hug it. So these are the four bones which make the 1/3 of the nasal cavity. And the cartilage part is the 2/3 of the cartilage, which make the rest of the nose. Well, each nasal cavity consists of a skin-lined portion, which is the vestibule, which is anterior, very small portion. And the mucosal lined portion is actually the nasal cavity proper. So we can divide the nasal cavities, each cavity into the nasal cavity proper and that's the vestibule, which is covered by skin. So if we go to the discussing the nasal walls, as it has already been discussed, a pyramid which has a roof and a floor and lateral walls, right? So the roof, if I can describe it, it has a sloping roof and the horizontal roof. The sloping roof in anterior 2/3, it's a cartilaginous roof, and in the posteriorly, it's made by the sloping, it's by the nasal bones, which join in the midline. And this posterior part of the middle part of the frontal this horizontal roof part of the roof is made by the ethmoid, the cribriform plate of the ethmoid bone, which of course have olfactory nerves pierced through it 10 to 12. Okay. Now I have to. Okay. Now we have to discuss the floor. Like it's the floor is formed by the palatine bones and maxillary palatine process of the maxillary bones, and the small portions are contributed from these surrounding bones, like this is the sphenoid and rostrum and the ethmoid spicules. They take part of that, but the major quadrangular part is actually made by this septal cartilage. And if we come down here, so part of the septum is actually membranous type, which is basically double side of the skin and some connective tissue. So if I sum up this septum, it has three parts. One is the columellar septum, which is formed of columella containing the medial crura of the ala cartilages united together by fibrous tissue and covered on either side by the skin. Like this is the most anterior part. And behind this columella, we have this membranous septum, which is consisting of double layer of the skin with no bony or cartilaginous support here. And it lies between the columella and the septal part of the cartilaginous part of the septum. And then behind we have this cartilaginous part of the septum, and then we have this bony part of the septum, which is perpendicular plate of this ethmoid bone and the vomer bone and the spicules of the surrounding bones, which form this septum. Well, on endoscopic view, we don't see all these bones and all this. What we see in endoscopic view, we see hair, skin with the hair follicles and hair, lot of secretions here. And then behind we see mucosa, which is in the lower 2/3, it's a pinkish color, and in the upper 1/3, it's a bit pale colored, which is actually the olfactory mucosa. Basically, the lateral wall is more of our navigation tool, because it has many landmarks and it guides us through the whole nose cavity to the base of the skull. So the lateral wall landmarks are very important. There are three or occasionally four separate the bony projections, which is actually called concha or turbinates. Like if you can see here, it's inferior turbinate and the middle turbinate and the superior turbinate. And sometimes in some cases, there is another fourth one, that is the supreme turbinate. The space behind this or beneath this turbinates is called myitis, which is actually the space where the nasal sinuses or various openings are there, like in inferior turbinate, inferior meatus, the nasolacrimal duct opens, which is covered by a famous Hasner wall of mucosal, and the middle turbinate, which is having the openings of the maxillary sinuses and sometimes the accessory maxillary sinus opening, and the middle ethmoidal air cells open in the as well here. When we come to the superior meatus, so frontal sinus opening here is in the superior meatus, and just medial and behind here we get the sphenoid sinus ostia. So if I discuss it a bit detailed, I think middle turbinate should be discussed because it has a bit complex anatomy. Middle turbinate is the part of actually ethmoid wall, and it is attached to the lateral wall by a bony lamella. We will be navigating through this via endoscopic video, but it's just for the sake of basic discussion. It is attached to the lateral wall by a bony lamella or ground basal lamella, which is it is termed like that. It is actually S-shaped attachment. This attachment need to be discussed because somehow when we outfracture it in the endoscopic endonasal surgeries, so it might cause CSF leak. So it is important to discuss. Initially, we were not understanding why it is getting a CSF leak, but in its anterior third, it's at S-shaped attachment, and in the anterior third, it lies in the sagittal plane, and it is attached to the lateral edge of the cribriform plate. And the middle third, it lies a bit in the frontal plane, and it has attachment with the lamina papyracea. And in the posterior third, it has some attachment with the lamina papyracea and medial wall of the sphenoid sinus. So the meatus of the middle, turbinate, it has some landmarks which are important for ENT surgeons and of course for us as well. Here, the blue structure which you can see it's a hook-like structure which is called uncinate process. It is important because if you can see just behind it, below and behind it at its lower end, here you can see an opening, and it is covered by just mucosa, and the ENT surgeon pierce through it and go through to this maxillary sinus. And the structure behind this uncinate process, there is elevated projection, and which is called bulla ethmoidalis, which is maybe a pneumatized structure or solid bony prominence depending upon pneumatization. Between these two structures, we have a shallow depression or a cleft, which is called hiatus seminolaris. And at the lower end of that is the opening of this maxillary sinus opening. Above and behind of this bulla ethmoidalis, we would be able to see in the video, there are spaces like the suprabullar space and retrobullar space, and which combinedly are called the recesses together called lateral sinus. And this sinus is bounded superiorly by the skull base, laterally by the lamina papyracea, and medially by the middle turbinate, and inferiorly by the bulla ethmoidalis. And it's probably the landmark for doing the optic nerve sheath fenestration through lamina papyracea. I haven't experienced yet. Okay, as I have discussed, it has opening of the maxillary sinus and or accessory opening and middle ethmoidal air cells opening. The superior turbinate, I have already discussed, is situated superior and posterior and superior to the middle turbinate. It forms an important landmark to identify ostium of the sphenoid sinus, which lies medial to it. The superior meatus is a space below the superior turbinate, and which houses this posterior ethmoid air cells open into it, and sphenoethmoidal recess is actually located medial and superior to the supreme or superior turbinate, and it gives us the landmark of the opening of the sphenoid sinus, which is very important in opening the sphenoid sinus. Very brief about the blood supply of the nose. Basically, it takes blood supply from the internal and external both carotid arteries. The internal carotid artery supplies through the ophthalmic division and then division into the anterior and posterior ethmoidal arteries. And the external carotid artery, it provides the major blood supply to the nose, both the septum and the lateral walls. And basically, it's two divisions, two branches, the facial artery and the maxillary artery supplies it. The facial artery contribution is less, but the maxillary artery basically has more contribution to the blood supply of the nose. And it is by two branches, that is, one is through the lesser palatine and greater palatine for the majority of the palate area, the floor and the lateral wall. And through sphenopalatine artery, it supplies the septal area and the rest of the nose. And this is majorly important. The sphenopalatine artery is important because we make the nasoseptal flap based on this sphenopalatine artery. And when we do dissections in the vicinity of the sinus, usually this artery bleeds and gives a big headache to the surgeon. Okay, nerve supply of the nasal cavity, it has three types of nerve supply. Like, obviously, it has olfactory nerve supply for the olfactory sensation, which is through the olfactory bulb, and 10 to 12 or 12 to 20 nerves pierce through this cribriform plate and supply this area. And interestingly, it may carry sheath of dura, arachnoid or pia with them. And sometimes even not by not injuring the cribriform plate, by just injuring these mucosa might cause CSF leak because of this these nerves carrying the pia and this dura and arachnoid with this these nerves. And a part of the olfactory nerves, we have other types of nerves, that is nerves for the common sensation, tactile sensation, or other sensation, and autonomic nerves. The nerves of the common sensation, there are many names here, probably may not be important for us, but one thing which is important, that all of these nerves from the branches are the branches of the trigeminal nerve. The upper third is supplied by ophthalmic division, the middle third of the nasal cavity by the maxillary division, and the lower third by the mandibular division. Autonomic nerves are both sympathetic and parasympathetic to the nose. This is important. If we could see, we usually get this radiology, and if you can see, a lot of details is there in the city. If you can see, this is the sphenoid sinus, and which has a septum which is in the coronal plane, and it has hyperpneumatized ethmoidal air cells and the frontal sinus, and it is attached or communicated with the ethmoidal cells. Here, if you can see in the nasal cavity, this is like, if you can see here, it is the bulla ethmoidalis. This one is the bulla ethmoidalis, and this space is this is hiatus semilinaris, and the middle concha can be represented here. This is the bridge of the nose and the cartilage, and this is the floor. The nasopharynx can be seen here, sphenoid sinus, and this is the clivus, the skull base, the cribriform, all area which can be seen. It's a bit lateral view, it's not in the midline, so cribriform probably is not visible here. This is what is more of our interest. It will be more presented in the next presentation, but for it is related to the videos which we are going to discuss and further. So we are seeing here. As you can see, it's an inside view of the base or the of the sphenoid sinus. Here are some impressions which are of surgical importance. The topmost here is the optic nerve impression. Here in the midline here is the optic chiasm, and on the lateral there is optic nerve. And these impression on both sides here and here, actually internal carotid artery impression, and the lateral OCRs, lateral opticocarotid recess here is visible. The medial OCR is not visible in here, and here the bone has been taken up from the floor of the sella, and the dura mater is visible. If you go up here, so we go into the anterior skull base, and it's a planus sphenoidal area for extension of the transsphenoidal surgery. And if you come down here, so we can come to the clivus. It's unlabeled, and another view, as you can see here in the optic impression, this is the planus sphenoidal area and the chiasma here, lateral OCR, the carotid impression beautifully shown here, and the clival area, the pituitary fossa, medial OCRs are visible. Here is endoscopic view. It's the right nostril endoscopic view. As you can see here, this is the lateral wall. This is the medial septum. Probably some DNS here on the right side. And you can see here, this is the middle turbinate and this is the inferior turbinate, the meatus of the middle turbinate, and this is the nasal cavity proper between this middle turbinate and the septum. And now we will be going to the choana. As you can see here is the choana, and this is the opening of the station on the right side. The first pass which we do in the endonasal transsphenoidal surgeries. This is the lamella of the attachment of S-shaped attachment of the sphenoid sinus. This is a middle turbinate. I will go to this next slide. It's again the right nostril and a bit here. It's a clear view. As you can see, the uncinate process, and behind it is the bulla ethmoidalis, and the space behind. You can see this beautiful space between the bulla ethmoidalis and this is the hiatus seminillaris, and we can go behind the bulla ethmoidalis for retrobulbar space, and here I can show you this suprabulbar space. I wish I could see entry into the lamina papyracea. It is somewhere here. Up and above. It's going up in a second. Okay, so we are in the meatus of the middle turbinate. Now we are coming out and going to nasal cavity proper, pushing the middle turbinate laterally, and this is our septum. We are going in the cleft, narrow space, potential space, and dilating it to reach. Actually, we have to find now the superior turbinate. This is superior turbinate, right? So by pushing this middle turbinate and now pushing this superior turbinate, we are able to see, yes, this sphenoid sinus ostia in the sphenoethmoidal recess. And now we will dilate it to look inside view of this sphenoid sinus. So this is all about the navigation through these landmarks, and relative knowledge and of the anatomy of all these landmarks guides us to reach to this point, and our work starts from here. The next video is a bit detailed dissection of inside of the nasal cavity, and in this video, we will be seeing the dissection through the left nostril and the right nostril, and the entire nasal septum from the cartilaginous to the bone will be taken, and both cavities will be communicated, and the clear view of the entire anatomy of the both lateral valve and the sphenoid sinus view will be visible. Here, at the start of the video, he takes the nasoseptal flap as well, luckily in dissection. So it's, as you can see, it's a first cut from superior 1/3 and inferior 2/3 junction. It's coming straight down at the cartilage and bony junction, but probably he's doing a bit proximal because for the sake of dissection, he's elevating this mucosa. It's being peeled off. Nasoseptal flap, as we all know, it's required for us while we are performing CSF rhinorrhea repairs, and if we are operating on the pituitary and we are expecting we need to repair this sella floor, so we make nasoseptal flap and place it in the choana, as we usually do it here. Now, after elevating, he's giving a second cut at the junction of the superior 1/3 and inferior 2/3, all the way posteriorly up to the keel, right? It's a bit 7-8 minutes video. It's very good to understand the basic navigational anatomy through this nasal cavity. Now he will be giving this last cut at the base of the septum and push it backward into the choana on the left side. We are working on the left side here. Yes, now it's being pushed in the choana. So this sphenopalatine artery branches is the sole blood supply to this nasoseptal Haddad flap. I hope it's not getting lengthy. So now this cartilage is being taken to elevate mucosa of the right side, and here he takes it so well, exposes the rostrum through this tunnel. I usually follow this, and I expose the rostrum and make entry through the rostrum into the sphenoid sinus, because a more consistent landmark and takes us to the middle of this sphenoid sinus. So the cartilage and the bone of this entire septum will be taken. Then the opposite side of the mucosa will be taken, and the whole of this nasal cavity would be made in a single room, and then the sphenoid sinus anatomy and everything would be visible in a proper navigated way. So as you can see, here is the mucosa of the left side of the nostril, and on the right side we can see the that is the right side of the nostril and mucosa, and on the left side we have the lateral wall of the nasal cavity. And this is the rostrum, which you can see. Now, when mucosa from the right side will be taken, the anatomy will get a bit clear. So now it's through the right nostril now. This cuts into the mucosa of the right nostril by cutting and removing it. It's an anatomical dissection, basically, not a surgical procedure. There you can see this sphenoid sinus ostia, which is visible. And this all mucosa is being taken down. Here we go. So now on the both side turbinates, superior turbinates, middle turbinates are visible, and this is the rostrum in the midline. And both ostia visible here. Okay. Here now, the sphenoid sinus is opened, the rostrum is taken, and you can see the keel. This is a nice view of the sphenoid sinus. I hope it will be discussed in the next presentation with full detail. But navigating to this is the goal of this presentation. So yeah, the septum in the sphenoid sinus is being taken, which is ipsilater on the left side. And it's all. Thank you for your patience. Thank you.
Excellent, Mohammed. Excellent presentation. That's very exhaustive coverage of the nose as it is needed. You know, I mean, I would have expected nothing less from you. So I know about the great work that you guys are doing in Pakistan. And at the end of this presentation, maybe I can do a 3-minute video on some of the new trends that we do. For example, brainstem tumors through the nose, or aneurysms through the nose and things like that. So we, and plus some, maybe 1 or 2 giant pituitary tumors where we advocate subdiaphragmatic dissection. So maybe at the end, I can show for about two or 3 minutes. But I guess we have a very exhaustive presentation this way. So the next speaker would be, I don't know how to pronounce this, Yücel Dogruel.
Yücel Dorel.
Yeah, okay. So Yücel Dorel from the Health Sciences University of Tepesik Training and Research Hospital in Izmir. He'll be talking about the anatomy of the nasal sinuses. So welcome, Yücel. All the best to you.
Thank you, Dr. Cherian. Hello, everyone. I will try to explain you today the nasal sinus anatomy, and I will try to focus more neurosurgical perspective. Paranasal sinuses are air-filled extensions of the nasal cavity, as all of you know, and they are four pairs, as namely frontal, ethmoidal, maxillary, sphenoid, and maxillary sinuses. They are located around the nasal cavity. Development of the sinuses are growing, they are enlarging by age. At birth, they are rudimentary or sometimes absent. Their enlargement rapidly increase during 6 or 7 years of birth, but still in elderly, with the resorption of the cancellous bone, they still may enlarge. So there are some discussions about their function. Are they like accessory spaces, or actually we can say they have functional contributions to the olfaction, humidification and warming of the inhalation, and impact on voice resonance. And also their structural laws is the reducing of the weight of the skull. And they have some immunological function, as they all covered by mucosa and mucosal immunity against pathogens. So I will start with frontal sinus. Frontal sinus is located in the frontal bone. It's between the inner and outer tables of the frontal bone, just above the orbit. The frontal sinus is variational, and both left and right sides can be variational among individuals or in same person. Also, they are asymmetrical. Here in yellow, I highlighted the frontal sinus. This is sagittal section of frontal sinus in cadaver, and you can see its close proximity, its relationship with the nasal cavity. So, as I mentioned, its anterior wall is created by the outer table of the frontal bone, and posterior wall is inner table of the frontal bone, which separates the sinus from the cranial cavity. Its floor, it's a thin bone. It separates the sinus with the orbit, and the medial wall of the sinus forms a septum between two sinuses. The frontal sinus is drains to the middle nasal meatus by the frontonasal ductus. It has very variational anatomy among individuals, and this is important for us, especially when we are preparing for transcranial surgeries. Also, there are some research about that, and it's found like the frontal sinus is usually larger in male patients. This is anterior cranial fossa of a cadaver, and when we open the superior inner table of the frontal bone, we can see here the frontal sinuses and their relations with the orbit. Its innervation, it comes from the supraorbital nerve, and its blood supply comes from the supraorbital artery. And here, as I mentioned, you can see the ductus frontonasalis, which drains the frontal sinus into the nasal cavity. Why frontal sinus anatomy is important for us? Like I said, when we are preparing for surgeries, for example, aneurysm clipping or bypass with supraorbital craniotomy, or when we approach for big tumors like olfactory groove meningiomas, preoperatively studying this patient's specific anatomy is important to tailor our craniotomy and approach. The second sinus is ethmoid sinus. They are air cavities in the lateral muscles of the ethmoid bone. Their roof is nearby the anterior cranial fossa and lateral to the cribriform plate. Its lateral wall, the orbit, optic nerve, and lacrimal duct locates. Inferiorly, it has relationship with maxillary sinus, and sphenoid sinus is located just posterior to it. In medially, its superior and middle turbinates creates its medial wall. The ethmoid sinuses divide into three different groups, which are anterior, middle, and posterior cells. The anterior and middle cells drain to middle nasal meatus, and posterior cells drain to superior nasal meatus. It's very variational, and it's very complex anatomy to master it. The neurovascular supply of the ethmoid sinus, it gets the anterior cells gets neurovascular supply from anterior ethmoidal nerve and vessels, while middle ethmoidal sinus gets supply from anterior nerve and vessels, and also branch from pterygopalatine ganglion. Posterior ethmoidal cells gets innervation and supply from posterior ethmoidal nerve and vessels, and some branches from pterygopalatine ganglion. Here I want to show a different perspective of the ethmoidal sinuses. You can see here a cadaver. These are the orbits, frontal bone, nasal bone. When we remove the nasal bone, we can see here the ethmoidal air cells bilaterally. And this is, as you see there, medial to the orbit, lateral to the middle nasal concha, and the sphenoid sinus just posterior to it. This is inferior view of the ethmoidal sinus. It's in a cadaver, it's like in maxillary sinus level axial cut, and we are looking from inferior. And here we can see the sphenoid sinus, and just anteriorly we can see the anterior, middle, and posterior group of ethmoidal sinuses. Why we should learn about ethmoidal sinuses? We are using transsphenoidal approach in many of the cases, and now we are seeing very good articles, research from from experts. But transethmoidal approach is still being in progress, and it's now being used like transnasal, ethmoidal approach to the especially medial nasal cavity and skull base. Sphenoid sinus, it's located at the sphenoid bone. In its superior, there is a pituitary gland and optic chiasm, and the olfactory bulb, and the frontal lobe. In its anterior wall, ethmoid bone and sinuses, and its lateral and superlateral wall, there is optic nerve. And its lateral wall, there is cavernous sinus, internal carotid artery, and third, fourth branch of the fifth and sixth cranial nerves. In its posterior wall, we can see the clivus and the basilar artery and brainstem. And here, an example of its lateral wall, there is carotid artery. This is summarizing the lateral, the structures located in the lateral wall of the sphenoid sinus, which are the optic nerve, the third, fourth, first and second divisions of the fifth nerve, the sixth nerve, and third division of the fifth nerve. When we use transsphenoidal sphenoid sinus anatomy is important for us in endoscopic and nasal transsphenoidal approach. So when we introduce the endoscope to the nasal cavity, you can see here in a cadaver left nostril approach, middle and inferior turbinates and nasal septum. So we go superior and deeper, and we can see the superior turbinate. Sometimes there are, in some patients, there can be variations as called supreme turbinate. The sphenoid we found by guiding this superior turbinate to find the sphenoid ostium. I'm passing this speedily because Dr. Khan is very good explaining this portion. When we find the sphenoid ostium, we get here from the mucosa to reach the sphenoid sinus. Here, mononostril approach, and now with binostril bilateral approach, we can see here the anteriorly there is sphenoid rostrum, and we can see here the optic canal and lateral opticocarotid recess. When we remove the rostrum, we can see bony laminas here, which is different in each patient, and in the lateral wall, the optic canal and lateral opticocarotid recess and sella. We should study the sella anatomy for each patient with paranasal sinus CTs. This is because of the sphenoidal segmentations are different in each individual, and sometimes these bony laminas can guide us to laterally, which can cause some complications. After we remove the bony laminas, here we can see the sella, and the internal carotid arteries are lateral, and this is the clival recess of the clivus. The next step of the transsphenoidal and pituitary surgery, we remove the bone of the sella, and there is sellar dura, and here we can see laterally the venous plexus of the cavernous sinus. Prechiasmatic sulcus of the optic chiasm is located just superiorly. And after we open the dura, here we can reach the pituitary gland, and we can manage the pathologies located there. Also, we can reach the posterior lobe of the pituitary gland. We can also use this corridor to reach the supra or infrachiasmatic corridors. We use this prechiasmatic sulcus. There is inferiorly medial opticocarotid recess, which we should be careful when we remove this bone. After we open this, after we remove the bone, there is a prechiasmatic sulcus dura. And the next step, after we remove the dura, we can see here the optic chiasm and optic nerves, and here is the optic canal, medial and lateral opticocarotid recesses. And if we introduce the endoscope, here we can see the suprachiasmatic and ephichiasmatic areas. Also, we can use this approach, this corridor, this sinus, to reach the planum sphenoidale pathologies. And planum sphenoidale bone, it's just superior to the prechiasmatic sulcus. And after we remove this bone, we can see the planum sphenoidale dura. And after we open the dura, here is the frontal lobe, gyrus rectus, and vascular structures. This is a summarize of actually sphenoid sinus. Here is the pituitary gland, infundibulum, and laterally located carotid arteries, here optic nerve. And this slide summarize the structures surrounding the sphenoid sinus. Maxillary sinus is, its anatomy was first defined by Nathaniel Highmore in 1651. That's why it's also called antrum of Highmore. It's located at the fossa canina of the maxillary bone, and it is the largest sinus and with pyramidal shape. The pyramidal shape, its base corresponds to the medial nasal bone, and apex comes to the zygomatic root. It is also the first developing sinus in the fourth gestational week. Its boundaries, like in the roof, it's close, it related with the orbit and infraorbital neurovascular complex. In its floor, there are close relationship with alveolar dental roots and alveolar process of the maxilla. In posterior, its posterior wall created by zygomatic and sphenoid bones, and we can reach infratemporal fossa here, and medially the nasal cavity. Its neurovascular supply comes to the arterial supply comes to branches of the maxillary artery, which are posterior superior alveolar artery, infraorbital artery, and descending palatine artery. Its innervation comes from branch of the maxillary nerve, which are middle, anterior, and posterior alveolar nerves, and infraorbital nerve. Here in a cadaver, we see inferior view in axial cut of maxillary sinus and its close relationship with its medial wall with the nasal septum. And here is the orbit, and these two asterisks corresponds to the infraorbital neurovascular complex. Maxillary sinus, interestingly, it's been using more than 100 years by ENT surgeons to treat different pathologies. But interestingly, the intraorbital lesions, it's not used for treatment of intraorbital lesions until recently. In 1998, Canardel has introduced a sublabial transmaxillary approach to orbital pathologies. After his introduction, only a few case presentations are used, and interestingly, it wasn't used for orbital pathologies. However, as I said, it's close relationship with the orbit, as it covers inferior wall of the orbit. It's also possible for orbital lesions, and I want to extend this portion of the topic a little bit. I want to show on a case how to reach the inferior orbital floor and remove lesions of the inferior orbital aspect. The patient is similar position to endoscopic transnasal surgery here. We use a above the tooth line, just leaving a small mucosal cuff, a small incision, starting from the frenulum until the second or third molar. After we dissect this mucosa, it allows us to reach anterior wall of the maxillary bone. It's also called fossa canina. And there we should take care of the infraorbital neurovascular complex which exits from the infraorbital foramen. Also, inferiorly, dental roots, we should take care of them because when we perform a maxillotomy to reach the maxillary sinus, we shouldn't damage the dental roots. After we remove the anterior wall of the maxillary sinus, the orbit is directly visible. This is in this patient, the mucosa of the maxillary sinus is removed, and here we can see the inferior aspect of the orbit. This is the floor of the orbit. After removing this part, it's easily accessible for these lesions. And the bone defect of the orbital floor can be repaired by some materials like synthetic bones. At the end of the surgery, after achieving the hemostasis, the maxillary bone can be placed anatomically. I studied on maxillary sinus on this approach, sublabial transmaxillary approach, and during that period, after I noticed that this natural anatomical cavity is not frequently used by neurosurgeons, there was like one possibility we don't know its anatomy well. That's why we are less using this natural anatomical corridor. So to address this issue, we described a solution like some segmentational process, and achieving three-dimensional models can address this problem. And in a model, you can study first surface anatomy. You can perform any kind of bone removal to study the anatomy of the maxillary sinus. Also, from virtual model, you can create also using 3D printers a physical model. You can simulate some surgical steps and check the anatomy of the approach. I want to show this in one case. This is a 34-year-old male, right-sided exophthalmos and visual problems. And here we see a lesion inferior to the optic nerve. This is three-dimensional view. It's from superior, lateral, and inferior views of the blue tumor. This is the visual field test in the affected site, in the lesion side. So like I said, it's the patient's placed in supine position, similar to the endoscopic transphenidal surgery. After the incision, we dissect the anterior mucosa to expose the maxillary sinus. Here, piriform aperture, medial wall of the maxillary sinus. And we are doing maxillotomy to remove anterior wall of the maxillary bone. And then we reach the nasal, the maxillary cavity, maxillary sinus cavity. After removing the mucosa, here we confirm our approach and the infraorbital neurovascular complex by neuronavigation, and also, as you see, easily we reach the orbital floor and the lesion. So after removing the orbital floor bone, here we expose the periorbital fascia. We extend our bone defect. We can extend if required with using Kerrison rongers. This is the periorbital fascia. As you see here, this natural anatomical cavity easily allows for access this orbital pathologies. Here, after we cut the periorbital fascia, the inferior rectus muscle, the periorbital fat tissue, and inside the fat tissue, we can see this lesion. We dissect the lesion, and I will just speed up this process and remove it with the big lesion and attached to the surrounding tissue. Hemostasis after removal of the lesion. This is endoscopic view of the maxillary sinus cavity. It's also this approach can be performed with only endoscopically. Case I am showing, this is a microsurgical case. Intraoperative MRI confirmed the resection, and we repair anatomically the orbital floor. We can suture the periorbital fascia. And reconstruct the orbital floor. After placing the maxillary bone, we can close the patient. As a conclusion, anatomy of the paranasal sinuses are variable. The sinuses enlarge by age. Neurosurgeons must understand this anatomy to perform complex procedures or adopt new techniques. Sinuses are key pathways in skull-based surgeries requiring precise navigation to reduce risk of complications. Detailed imaging and understanding sinus anatomy enhance surgical safety and outcomes, and this reduces the risk of CSF leaks. I would like to thank Dr. Güngör, who helped me in this presentation. Thank you.
Yücel, excellent presentation. Very good. I would, I mean, this is a completely new approach to the orbit, the sublabial transmaxillary approach. Excellent. Very good presentation. Now I'll call upon Amit to have his presentation. I know Amit from a long time. So when I was in Nepal, I remember he's an excellent surgeon. So I would look forward to his presentation now.
Yeah, thank you. Thank you for this introduction, Ayub, and hope to see you in person soon. Before I start, let me thank Dr. Emmas for inviting me, for having me here, and an excellent talk by our previous speaker. Both Dr. Nawaz and Dr. Yusuf have been very elegant in their talk. And let me share my slide. And well, I have been given a task to present on sphenoid bones and sella turcica. And mind you, this is the bone which is of very much interest nowadays amongst the young neurosurgeons, because the shift of focus initially when I was a trainee was much more on a temporal bone. In every meeting, they used to talk on temporal and the petrous bones. But nowadays, since the endoscopy has come into vogue, now everybody is talking about sphenoid bones and the way to approach the sella turcica as well as beyond it. So I don't have anything significant to disclose in this presentation, except for this fact that I have taken most of my pictures from Rotten and other website, which I have acknowledged them by their putting their names on the slides. And this is a pure education and sharing experiences. So this particular discussion is about why are we doing this? So why are we studying the sphenoid bone and the sella, and what is about the sphenoid bone? What are the anatomical parts and landmarks? The surgical importance about it and the surgical approaches in and around sphenoid. So when I was trying to prepare this slide, I just came across a website, a very interesting fact about the sphenoid bone, where one of the website blogger was putting it as a cause of lot of ailments, headaches, migraines, temporomandibular joint disorders, and likewise. But our interest as a neurosurgeon is to understand these bones, not only to understand the access to the surgical vision for cure, decompression, biopsy, but also to protect the vital structures, restore the key anatomical barriers, and also to have the functional and aesthetic reconstructions. So from these viewpoint, from a neurosurgical viewpoint, I will be presenting this talk. So when we see the sphenoid bone, this is in the shape of a butterfly. And as in renderation by an artist, you can see this particular bone has a paired lesser wing, and then a paired greater wing on the side. Then it has a sphenoid body and a paired processes of medial and the lateral pterygoid. And it has a structure which looks like a butterfly from different perspectives, from anterior as well as the posterior view. And then in the superior and the inferior view, one can appreciate that the overall layout of the bone in such a manner that is much more placed vertically as compared to the horizontal placement. And the name sphenoid as such has derived from a Greek word called sphenodial, so which means basically wedge. So this is wedge between the anterior and the middle cranial fossa, and it actually gives a sort of a junction between the anterior and middle fossas. Now it is completely hidden beneath, and it can be seen very small in quantity in the lateral view as well as through the orbit. And every young neurosurgeon who has his hands on the skull, once he starts making a craniotomy, has to go through this bone whenever he's going through the terrenal craniotomies. And just on again an anatomical rendition, one can see that how hidden it is to access it. And that's why it is supposed to be a very complicated bone to understand. But once we like to play with this bone in the 360 degree, we will be having a good idea about it. So this sphenoid bone makes one of the 5 bones, which is the component of the skull base and has a junction with the ethmoid in the front and the frontal on the sides. And then with the temporal bone on the side, and it continues in the calvaria in the form of a parietal bone, in license the parietal bone. And in the posterior aspect, in the posterior cranial fossa, in the midline, it is to the occiput, and in conjunction with the temporal squamous portion as well as the petrous, it forms the posterior portion of the middle fossa. Now, when we understand the attachment, which is very important, particularly from the endonasal perspective side, if we see the anterior aspect of the sphenoid bone, in the midline, it is attached to the sphenoid in the front and the vomer in the bottom, and then the palatine bone on the side as it comes anterior from the front. So this is the same picture which has been inverted upside down. Then when we see the maxilla coming in the front, the maxilla actually sits in front of the palatine as well as the vomer. And if you see this particular orbital roof, as Dr. Yusel was also elucidating to his presentation, this makes the component of the orbital cavity. And then this orbital cavity is actually made complete by the palatine bone on the medial aspect, and then the frontal orbital process of the frontal bone, which comes and sits on its top. So this sphenoid bone does not only makes the middle cranial fossa, but also makes a very important component of the orbit. And then when we go from onto the back, we see from the exocalvarial aspect or the exocranial aspect, where the bone is facing the soft tissues outside the brain component, it has a zygophyseal attachments to the occiput and the temporal bone on the sides. And then when we come inside, it has, again, these type of attachments, which is basically completing the middle cranial fossa and posteriorly the posterior cranial fossa. Now we will be discussing each of these views in detail. So when we see the sphenoid bone bang anteriorly, it looks like a butterfly with a keel in the front, which is also the sphenoid keel, and it has two ostias on the side, which leads into the sphenoid air sinuses, which we usually open to reach the sellar floor. And then on the side, between the lesser wing and the greater wing, is the superior orbital fissure. And this superior orbital fissure is separated from the foramen rotundum by a maxillary strut. And then when we come medially on the inferior aspect, this is the pterygoid canal, where the nerve of the pterygoid canal, also known as median nerve, comes through it. And this is a very important landmark when we are going a lateral approach in the transnasal sinuses. And then in the inferior aspect, we have the pterygoid processes, the medial and the lateral. And this is important from the front because most of the nerve, which the cranial nerve 2, 3, 4, as well as the V2, which comes out from the skull base, actually comes out through the various foramens, which is lying in the anterior aspect of the sphenoid bone. So this is the optic nerve, which comes out the optic foramen, and then the 3, 4, 6, as well as the branches of the V1 would be coming from the superior orbital fissure. Then the foramen rotundum, where the maxillary nerve will be coming out. So all these nerves comes out through the different foramina, which is lying in the anterior aspect. Now, when we come from the backward, from the post, when we look at the superior orbital fissure, the superior orbital fissure, in which has an optic canal on its top, and it's separated by optic strut in between, is just covered by annulus of Zun, which is basically a muscular tendinous strain, which has an optic nerve and ophthalmic artery inside it, and then the cranial nerve 3 and 6 together with the nasociliary nerve sitting inside it. Now, this is also known as orbital apex, and that's why, since we see some of the nerves are coming out, or they are going out of these annulus ring, which is basically the lacrimal nerve and the frontal nerve and the cranial nerve 4, or the trochlear nerve. So whenever the patient is having an orbital apex syndrome, he will have ptosis, he will have proptosis, but he will not have the involvement of SO4 or superior oblique. Why? Because the cranial nerve 4 is sitting outside this annulus of Zim. So this is again artistic rendition of the same, which we are talking about. And then the maxillary bone, or the orbital part of the maxillary bone, together with the greater sphenoid ring, which actually forms the inferior orbital fissure. So through which the infraorbital nerve and the zygomatic nerves flows throughout. Now, when we see this particular sphenoid bone from the posterior aspect, this is very important from the vascular point of view, because the carotid artery, which comes out of the foramen lacerum, goes to the carotid cave. So the carotid caves are the bony impression, which is seen on the medial aspect of the body of the sphenoid. And the carotid cave actually allows the carotid artery to sit on it. And as the carotid artery goes through a 2 centimeter long horizontal segment, it turns upside up towards the anterior clonoid, and it comes out of the anterior clonoid medially. And this particular segment is known as cavernous sinus, which actually goes from the superior orbital fissure and ends up to the petrous apex. So this is very important from this aspect. And when we see the sphenoid bone from the top, one can visualize the sella turcica, which is basically bordered on the front by tuberculum celli, and then there is a depression which is known as hypophysis sella, and then there's a dorsum celli at the back, and the dorsum sella is actually bounded by posterior clonoid on the either ends. Now, anterior to the tuberculum sella is the prechiasmatic sulcus, where the chiasma sits on it, and in front of it is the limbus of the sphenoid, and then again in front of it is the jugum sphenoidal, also known as planum sphenoidale, which Dr. Yusel was also speaking in his presentation about. So this is from the endocranial aspect of the bone, which is actually facing the brain aspect. And then we can have a view of the foramen ovale and the foramen rotundum. So this, and then also the foramen spinosum. So foramen ovale gives a passage to the cranial nerve V3, that is the mandibular segment of the trigeminal nerve, and the foramen rotundum gives the way to the maxillary nerve. And the foramen spinosum is the outlet for the middle meningeal artery, which is important when we are doing a middle fossa approach. Now, when we see this bone from the inferior aspect, we see the basically the pterygoid plates, which is hanging up out, and then there is a pterygopalatine fossa, which actually goes laterally to communicate with the infratemporal fossas. So when this particular view from the right oblique is important for us to understand the optic strut. So if you remember, optic strut is the separation between the optic canal and the superior orbital fissure, and is also the posterior root of the anterior clinoid process, which I will be discussing in detail in the coming slides. Now, this is a superior oblique view of the same bone where you can appreciate the anterior clinoid process and its three processes. So the three process is one of the medial root, which makes the roof of the optic canal, then the optic strut, which is the posterior root, and then there is a process which attaches to the lesser wing. So these are the three processes of the anterior clinoid ring. Now, as we have discussed, the carotid, internal carotid ICA, internal carotid artery, comes out of the foramen nassarum and through the underneath the lingual ligament, petrolingual ligament. It comes into the clinoidal segment, and once it into the clinoidal segment, it goes through the lower dural ring into the clinoidal segment and comes out of the clinoidal segment outside the upper dural ring. So this is how the carotid flows, and there is an entity known as kissing carotid, which every endoscopic surgeon should be well aware of. So sometimes the carotid comes very near to each other, and when both of these carotids, they are very near to each other, they becomes a dangerous point to hit on the transsphenoidal approaches, because the carotid come into the way, and this particular kissing carotid can occur not only inside the sella, but also in the clinoidal segment. Now, this is an artistic rendition. This is a cadaveric specimen to suggest how is the layout of the cerebrum as well as the ventricle in relation to this middle part of the sphenoid. So one can see the pituitary gland is sitting in this the hypophysis sella, and just above it is the chiasma, and then there is a lamina terminalis, and then the third ventricle. So, and then the anterior circle of Venus is sitting on its top. So any lesion which arises from the sella can actually go up and can cause a compression as well as involvement of these structures. So one should be aware of that. And similarly, in the coronal view, one can actually see that the temporal lobes, the medial temporal lobe is sitting very lateral to the sphenoid sinuses, and that's why the lesions can actually involve the temporal lobes there. Now, what is important for us to understand is that this sphenoid bone, since it is the layout of the sphenoid bone is much more vertical as compared to the horizontal. It is not creating a sort of a bowl for the brain content, but it is actually giving a passage for a lot of nerves and the vessels to flow across. So it gives a passages from cranial of 2 to a cranial of 6. Which actually passes very near to this sphenoid and over this sphenoid to the various anterior skull base and the middle skull base. And then there's a passage to the ICA, which is also very important to consider. So when we talk of ICA, we know that the cavernous ICA, which is actually coming out of the foramen nassarum and entering to the cavernous segment, it has only basically, it has been said to have 3 different branches: meningohyphacial trunk, then it can have an infralateral trunk, and can, in some cases, it can have a different artery. So the variations can occur. But when it comes out of the clinoidal segment, inside the clinoidal segment, it gives an ophthalmic artery, which comes underneath the optic nerve. And this particular segment is very important, the clinoidal segment, because this is the only segment which has 2 dural sheaths. So one should be aware of that when they're trying to dissect this particular area. Now, this is a cadaver which can show us the relationship of the anterior and the middle cranial fossa with the base. So once we take out the orbit, we can see that the sella, the sphenoid sinus, is basically is sitting in the mid of the middle cranial fossa, and this particular pterygopalatine fossa and the inferior fossa are actually the lateral component which is sitting below the middle cranial fossa. And then we can see that the foramen rotundum is coming out into the pterygopalatine fossa, and then the mandatory nerve is coming out into the through the foramen of ovale into the infratemporal fossas. Now, this particular picture also suggests the same, and this is a very brief area for pterygopalatine fossa, which actually houses the pterygopalatine ganglion as well as the maxillary artery when it is coming out into the infratemporal fossa. Now, the most important structure, which from the vascular point of view, which most of the people have a difficulty to understand in relation to the sphenoid, is the cavernous sinus. So cavernous sinus is nothing but an interdural sheath. So these are two layers of sheath, which is actually making a sort of a keel of a boat, which has a top deck and a very narrow base. So this particular keel actually starts from the superior orbital fissure, as you can see here, and then it goes backward, and the posterior border is between the posterior clinoid and the petrous apex. And the base of the cavernous sinus is basically made by the junction of the median and the lateral dural fold, which is attaching itself underneath the internal carotid artery. Now, the roof is actually again formed by the dural fold over the petrous apex, over the anterior clinoid, and then there are three ligaments, three dural folds one should be aware of, which is important. One is the anterior petroclinoid ligament, which is basically the dural fold starting from the anterior clinoid till the petrous apex. Then the posterior border is made by the posterior petroclinoid fold, which is basically from the posterior clinoid process and the petrous apex, and the interclinoid fold, which is between the anterior clinoid and the posterior clinoid. So one can see in this figure also that the oculomotor nerve, together with the fourth nerve, passes through the roof of the cavernous sinus and goes through it. However, the sixth nerve and the V1 actually flows through the lateral wall of the cavernous sinus, and V2 and V3 are completely outside the cavernous sinus. So this particular investing fascia is very important for us to understand, because this gives a very good idea about how the cavernous sinus layout is all about. And one can also see in this figure that the IC is coming out of the outer dural ring in this particular film. So cavernous sinus is basically a highway for all the veins from the anterior cranial fossa, from the posterior cranial fossa, as well as the middle cranial fossa to flow through it. And they also communicate with the other side through the anterior intercavernous sinus and the posterior intercavernous sinus, which is seen when we are coming from the endonasal route. And that's why this particular channel is very important for us to understand, because it has a lot of things into it. Now, when we see this particular thing from the top, this is how it looks like. So this is an optic nerve, and this is the ICA, which is coming below it. This is the fascia, which is this is the dura, which is covering the anterior clinoid process, and this is the oculomotor nerve, which is entering into the oculomotor triangle. Now, when we see these dural attachments, and the most important dural attachment, which is also need to be understood, is a falciform ligament. So falciform ligament is nothing but which actually makes the roof of the optic canal, and this is very important when there is some tuberculum cellar meningioma or some other tumors which is involving the optic, which is causing an optic compression. So we have to actually decompress the roof in these cases. So falciform ligaments needs to be cut. And then this is a triangle which is basically made by the optic nerve and the oculomotor, which is also known as clinoidal triangle. So the clinoidal triangle is one of the cavernous triangle, which is, once you open it, you can see this is the clinoid segment, clinoidal process, anterior clinoid process, and the ICA, which is basically the component of the clinoidal triangles. And the ring which I was mentioning about, the lower ring and the upper ring are basically the dural investments, which is actually coming up. In the case of the upper ring, it is coming from the superior surface of the anterior clinoid process and covering the ICA when it is coming out of the clinoidal segment, whereas the lower ring is the dura, which is coming from the lower aspect of the anterior clinoid process and covering the lower part of the ICA. So the ICA takes a bend between these lower and the upper ring, and that forms the clinodal segment of the ICA. Now, this particular triangle, which we have just mentioned about it is formed by the convergence of the two nerves, and that's why most of the triangle which is formed over the cavernous sinuses are due to the convergence of these nerves. So in this case, there's the clinodial triangle, which we have just mentioned, and this is on the lateral view. So one can see the ICA as well as the anterior clenoid process after it has been truncated. Then the other triangle which is important for us to understand is the oculomotor triangle, which is another cavernous sinus triangle, which is made by the lateral fold of the anteropetroclinoidal fold. Then the posterior part is the posterior clinoidal petroclinoidal fold, and then the interdural fold actually makes the middle component, and the mid part of the oculomotor triangle is the entry of the oculomotor nerve into the cavernous sinus. So this is how it looks like in the lateral view. Then the third triangle, which is important for us to understand, is the supratrochlear triangle, which is formed by the lower aspect of the oculomotor nerve and then the superior portion of the trochlear nerve. And then the posterior portion is the dural side entry of the third nerve and the fourth nerve. So this is a very narrow triangle. And then the other triangle is the infratrochlear triangle, which is formed by the lower portion of the trochlear nerve and then the upper part of the V1, and then the posterior border is made by the dural entry side of these two nerves. So this particular triangle is also known as Parkinson triangle, and Parkinson once thought that this particular area can give a solution to the most of the caroticavernous fistula, because meningococcygeal artery is believed to arise from this particular part of the ICA, which is hidden underneath. Then is the four triangles, which is important from the perspective of the middle fossa. But then these four triangles, the two triangles, the anterior medial and the anterior lateral, are the ones which are lying over the sphenoid bones. The other two, that is the posterior medial and the posterior lateral, are lying over the petrous bones. So they may not be the part of the sphenoid bone which is in the discussion right now. So when we talk of anterior-medial triangle, which is made by the divergence of the V1 and the V2 nerve root, and it is made, and the anterior border is made by the junction of the line from the superior orbital fissure to the foramen rotundum. This gives an access to the maxillary sinus. And similarly, the anterior-lateral triangle, which is made by the lower aspect or the outer aspect of the V2 and the middle aspect of the V3, and then the line joining the foramen rotundum to the foramen ovale is the anterolateral triangle, which again gives access to the sphincter sinus. Then just to mention here is the posterolateral triangle, also known as Glasscock triangle, which is made by the outer aspect of the V3. And then the posterior medial aspect is made by the GSPN, which is flowing underneath the V3 segment. So this actually makes the Glasgow triangle. And then the fourth triangle, to just complete the list, is the triangle which is made by the medially from the V3 and between the GSPN, and this gives an access to the posterior fossa. So the other important structure which we have been discussing in few of the slides before has been the anterior clenoid process. Now this is a very important process, because once we go through the neuroanatomy or we do an FTUZ and we want to access the middle fossa base or the cavernous sinus, and this particular clenoid tip has to go off. And similarly, in the most of the cases of an ICA, clenoidal segment aneurysm or ophthalmic segment aneurysm, we need to take off the clenoid process. So when we take off the clenoid process, there are two ways to open the clenoid process. One is extradurally, the other one is intradurally. So the extradural process actually comes from the outside, and once you start drilling once you get to the superior orbital fissure, we just cut through the orbitomeningeal band, and then the anterior clenoid tip is in front of it, and then we start drilling the anterior clenoid tip in a form of a coding process. So we just eat up the mid portion of the bone, and then we just take the optic strut out, and then the whole anterior clenoid process actually comes out like a tooth. So that actually gives us a method to open up the anterior clenoid process. And the other method, as we have just mentioned in a few slides before, is to open up the falciform ligament and then come from medial to lateral. So this actually opens up the optic canal, as well as you can see the ICA is open after this anterior clonidectomy for any of the clipping of the clonoidal segment aneurysms. Now, middle fossa approach, particularly the Hakuba's techniques, also uses this particular technique of going from the front to back and to dissect the cavernous sinus. I will not go into this operative detail because that's it's outside the purview of this talk. Now, coming to the endonasal route. So our previous speakers have already explained many things in detail. There are a few things I would like to highlight here is the sphenoid ostium, which is basically the key landmark to enter into the sphenoid. So as the speakers have already told that it is at the level of the at the level of the superior turbinate, but sometimes the anatomical variation may misguide you. So the most important landmark would be the choana. So the roof of the choana had to be usually between 2 to 3 centimeters above. You will see the sphenoid ostium, and through the sphenoid ostium, one can enter into it. And the sphenoidal penetral artery is the most important artery to understand if you are raising the Hadad flap, because it cannot be sacrificed if in case we are trying to do that. So it's always better to make a Hadad flap in such a manner that you come below the sphenoid ostium, and that the superior limb of the flap comes above the ostium. So that's why the sphenopalatal artery can be preserved whenever we are trying to raise the Hadad flap. Now, when we go inside, we have already talked about MOCR and LOCR. So MOCR is nothing but the lateral most extent of the tuberculum sella. And this is the area where we'll be getting the internal carotid artery, where it takes a turn inside the clinoid. And the LOCR is nothing but the anterior clinoid process, which is actually we are looking from the outside from the sella. So anterior clinoid process is basically the LOCR, and now it has come into too much of prominence because of many of the para-optic approaches which has been defined, which plays around the LOCR dissections. And so this is now coming into a lot of discussion these days. And similarly, the sella dura, which gets actually below the tuberculum and in front of the clival recess, is the base of these pituitary, where we open up. And the pituitary gland is actually attached laterally through these bands to the cavernous sinus. And if we have to translocate the pituitary gland, then we have to cut through these bands so that the pituitary translocation can be done. So previously, we used to do like a depression of the pituitary gland to go into the posterior fossa. But nowadays, we have found that one of the bands can be cut and the pituitary can be shifted to one side to go into the posterior fossa through this. So this is another method by which we can go through the posterior fossa through this route. So sella turcica, also known as the Turkish saddle, is actually sitting there, and we have already discussed about the anatomical landmark of the sella turcica. So just to recapitulate, it is the tuberculum sella, which is in the front, and at the hypophyseal fossa, and then the dorsum sella, and it is bounded by the posterior clinoid process. So there is a thing also known as middle clinoid process. One should be aware of this variation. Sometimes the middle clinoid process together with the anterior clinoid process can make a bony canal like this. So this makes a bony canal for the internal carotid artery as it comes out of the clinoidal segment. And one should be aware of this entity before going to this area for the ACP dissections. Now, a few brief about the CT scan finding, because sphenoid air sinuses we have already discussed as basically a route through the endoscopic approaches. So whenever we are going through these particular approaches, we should also be considering how much pneumatization has occurred into the sphenoid. So sometimes the posterior ethmoidal cells can go inside the tip of the anterior clinoid process, which is also known as Onrodi cells. So whenever we are opening the anterior clinoid process, one should be cognizant of this fact, or else the patient may land up with a CSF rhinorrhea later on. Similarly, is the condition of the pneumatization of the sella, which should be appreciated. So if the pneumatization is restricted only to the tuberculum celli, then we call it a pre-sellar pneumatization, and these are very difficult bone to to drill through to reach the sella. And the most appropriate is the sellar pneumatization, where the whole floor of the sella is actually pneumatized. And if the pneumatization reaches up to the dorsum celli, we call it as a post sella. And actually, this particular pneumatization variation actually allows a very good access to the clivus from the transsphenoidal approaches. So other than that, one should be also aware of the pneumatization which is there between the foramen rotundum and Vidian canal, because as I've already told in the endoscopic approaches, we need to know this Vidian canal and the Vidian nerve as it is coming out. So whenever there's a pneumatization has occurred, very less drilling is required and one can easily go through it. And similarly, this is another CT scan view where one can see the ICA, the Vidian canal coming out through the los foramen lacerum. So the foramen lacerum, you know, the deep petrosal nerves joins GSPN to form the Vidian canal, Vidian nerve, and the Vidian nerve actually comes into the pterygopalatine fossa through this. And then this particular CT scan actually shows the communication between the middle cranial fossa and the pterygopalatine fossa through the foramen rotundum. And here in this particular CT scan, one can see the superior orbital fissure and then the optic nerve going through the optic canal. So just a brief about how we are actually exposing this particular bone in our routine surgeries. So we all know neuroanatomy is a workhorse of the neurosurgeons these days. And the neuroanatomy concept is just like a cone. So wherever we are trying to base our focus, that particular cone should be actually either be put forward or backward, can be put upward or downward accordingly to reach that particular thing at the base. So whenever we want to go much more posteriorly or towards the middle cranial fossa, we want to come much more, and we want to expose it much more from the front, so frontozygomatic approaches. And similarly, when we are trying to go into the sella, to the cavernous sinus and other approaches, then we go from the middle fossa approaches. And nowadays, people are becoming much more focused in the minimal invasive surgery era. So people are talking of mini-terunal and even micro-terunal craniotomies. So that's just a variation, but then most of these approaches goes to this sphenoid wing into the anterior cranial process. So beside this, one should also be aware that whenever we are planning any skull basis approach, this is the axial view which we should always consider. So this is for the residents who are listening to this presentation. So this is very important for us to appreciate the axial view, because this will give us an extent about how much we can approach. And then through the sphenoid, the other corridors which we have been discussing in the last many decades had been through the subappendibal approaches. But with the advent of the endoscope, we are doing a lot more of these surgeries by an endoscope. So there are two lines which everyone should be aware of. One is the superior line, which actually attaches the nostril to the floor of the pituitary fossa. So this anything above it is known as transcellular corridor. So it actually gives a very good view to the pituitary gland. And below it, depending upon the pneumatization of the sella, which can give you an approach to the posterior aspect of the clivus. And then the second line is the inferior line, which attaches the nostril to the floor of the pneumatized sphenoid. So anything below this inferior line is the infrasphenoidal corridor. So in this case, you can actually go transclaval without going through the sphenoid sinus. So air sinuses have been in vogue because these are actually the passages to a lot of the structures, both midline as well as on the lateral aspect. So I won't go into detail about this. So to summarize here, the sphenoid bone actually forms the anterior and the middle skull bases. It has attachments to both the skull base and calvular bones. And we need to study our CT scans properly to know the vascular and the sinus anatomy, as well as to make our plan as to how the surgical approaches has to be made. And anatomy is very important to identify the key strategies to access the lesion inside or hidden behind. Thank you for your patience listening. And I have some physiological videos also to show, but then in the sake of time, I will skip that and I hand over to you, and I will answer any queries if in case there are. Thank you.
Amit, excellent presentation. Very good. So, I mean, I just wanted to raise a few points right now. Give me a second, guys. Give me a second.
Thank you, Professor, for this nice presentation. Very excellent and very nice pictures and very nice sections and very nice explanation. We all enjoy this lecture. Thank you very much. And also thank you to Dr. Mohammed Nawaz and Dr. Yusil Dorel for their presentations as well. Dr. Ibe?
Yeah, so first few things. Number one, the sinuses for UGL. We have a large publication in two publications and a textbook chapter on how the sinuses helps the brain to cool. So maybe you guys should read up, and then I'm going to share my screen and show you some of the frontline work that we've been doing when it comes to endonasal approaches. So I'm just going to share my screen. Can you see my screen?
Yeah.
You can see my screen?
Yes, it
Yes,
is.
yes, we can see it.
All right. So first thing is the subdiaphragmatic dissection. That's the most important thing. So when you have large pituitary tumors like this, for example, what is important is that you must always be under the diaphragm. When I see people doing pituitaries from above, one of the things that they take out saying it's a capsule is with the diaphragm. So you must understand the pituitary stalk pierces the diaphragm and goes. So when you take the diaphragm off, that means you are cutting the stalk and creating, irreversible DI. So this is what we're going to show. So see, it's a pituitary. It's a 3-minute video, everything together. So you can see how large it's pituitary. It's a solid tumor. But after we've done it, we're starting from 2 o'clock, and then from 2 o'clock to 10 o'clock, we're finding the diaphragm. And once we find the diaphragm, we dissect the tumor off that. That's most important. So keeping on removing microsurgically, you keep on removing the tumor under high zoom, and you will see that the tumor is completely removed, and this patient doesn't have any pituitary dysfunction. Generally, you would expect pituitary dysfunction with this kind of tumor resection, but then you won't have any tumor. This is another case where this is a brainstem lesion. It's a pilocytic astrocytoma. So you can see the basilar is completely displaced to the right side. So to get a window here, what you must do is the sixth nerve is here. The sixth nerve must be lateralized. So Amit was talking about some of the ligaments. So to lateralize the sixth nerve, what you need to do is you need to come in here, medial to the paraclival carotid, and after that cut the PPCL, the posterior petroclinoid ligament and the petrosphenoid ligament, and then lateralize the sixth nerve, and you have a huge window here. Only thing is you have the perforators here. So you will see that. Right now, what you're going to see is you're going to see this tumor here. You can see the basilar in front. And you can see how this is, and that's why we chose this approach. So that's the paraclival carotids. That's the sella. So we're going to remove off the PCPs here. We're going to drill and remove the PCPs here. First, you identify the sella, and then you're removing the PCPs there. On the left side, we'll remove the PCPs and then go in. So that's a drilling of the PCP. The sella is being displaced upwards, clivus, upper clivus, and then the PCP, which is connected to the upper clivus, is being removed. Once you do that, then you can go in there, and that's your vertebral artery. And because the basilar is displaced completely to the right side, now you're going to the left side, and that's a released sixth nerve. That's the sixth nerve which is released. PPCL and PSL released, and that's a Gulfar segment of the cavernous sinus. You stop the bleeding with the glue, and after that, this is the vertebral artery. This is the basilar artery. This is the perforator. There's a basilar perforator there, and you can remove the tumor there. Okay, so this is how after the tumor removal looks like it. So she's been on follow-up for 4 years. This is an endoscopic this endoscope holder. So this is how we use it. My ENT colleague is using it. This is designed by us. This is another case where we are clipping pica aneurysms. We now started clipping posterior circulation aneurysms with this approach. With the headed flap, it's beautiful. So this is a pica aneurysm. So it's apparently the second case in the world. So you can see that's a pica. That's a pica there. That's a 12th nerve roots. And then you can see we put in a temporary clip first to check the aneurysm, dissect the aneurysm. So that's aneurysm being dissected out there. And once you dissect out this aneurysm, then you can put in this clip. So we've started using a lot of 3D endoscopes. So we have the Einstein Vision, which is a 3D endoscope from Esculap. So that's an excellent, that's a game changer, I must say. And then we have the endoscopic holder, the robotic holder. So we don't have much time to show all this in detail, but I'm just showing this much thing. So that's a neurocongress that we organized recently. We had the president of the WFNS come here. So thank you very much and excellent talks, everybody. God bless and fantastic conference, Ahmed and Ujel, then Nawaz and Amit. Excellent talks. Thank you very much.
Thank you, everyone. And by this, I think we can conclude this session. And with this great presentations by each of Dr. Muhammad Nawaz and Dr. Yusil Turel and Dr. Amit Thaba. Thank you, everyone. And thank you, Dr. Aib, for moderating this session. And thank you, everyone. And to the next Friday, inshallah, we'll have another session. First, we'll have a presentation about anatomy of the anterior fossa by Dr. Aib Cherian, and then anatomy of the middle fossa by Dr. Let's check. Okay. Sorry for that. So next Friday, we'll have anatomy of the orbit and its contents by Dr. Mahjibin Mimoun, and then anatomy of the anterior skull base by Dr. Aib Cherian, and last we'll have anatomy of the middle cranial fossa and the microsurgical approaches by Dr. Victor Hugo Perez. So thank you, everyone, and until next week, we can meet, inshallah. Thank you, everyone.
Thank you.